The clients who would benefit the most from this therapy approach are children with moderate to severe phonological disorders. Most clients have at least 6 sounds that are missing from their phonemic and phonetic inventories. The type of assessments that could determine which children fit into this description are an oral mechanism exam, hearing screening, conversational speech-language sample, Goldman-Fristow Test of Articulation 2, Kahn-Lewis Phonological Assessment, and the clinical evaluation of language fundamentals. Once it is determined that a child would benefit from the maximal oppositions therapy, the clinician must select target sounds. These should be 2 sounds that are not in the child's sound inventory. These 2 sounds should be maximally different according to their distinctive features.
To obtain baseline data, the clinician will elicit 10 trials of each sound that were not found in the child's sound inventory. The clinician will record each production as either correct or incorrect and use the percentages to determine which sounds need to be targeted first. Age appropriateness of target sounds will also be considered. Maximal oppositions therapy chooses sounds that are very different in distinctive features. The 2 qualifications of sounds chosen are the number of unique features, place, manner, and voicing, and the natures of the features, consonantal, sonorant, and vocalic. The pairs presented contain 1 sound that the child is familiar with and a target sound. There are 2 phases in the maximal oppositions therapy sequence. The first phase is the imitation phase. In this phase, minimal pair picture cards are presented and the client imitates the clinician's correct production. This phase continues until 75% accuracy is achieved for 2 to 7 sessions. The next phase of therapy is the spontaneous phase. In this phase, minimal pair picture cards are presented and the client spontaneously produces the word pair. This phase continues until 90% accuracy is achieved for 3 to 12 consecutive sessions.
To collect data, the clinician will judge the client's productions as correct or incorrect and mark on a data collection sheet using a plus or minus. This will continue until 75% accuracy has been achieved for 2 to 7 sessions for the imitation phase and until 90% accuracy has been achieved for 3 to 12 sessions for the spontaneous phase. The clinician will use reinforcement strategies to increase correct productions. In the case of a correct production, the clinician will give the client verbal praise or a high five. If the client uses an incorrect production, the clinician will encourage self-awareness and model the correct production for the client.
Cat, rat. Cat, rat. Good job with your and k sound. Lose, shoes.
Lose, shoes.
Okay, when you say lose, we want to make sure you put your tongue tip up on your magic spot. Lose.
Lose.
Good job with your l sound. Ran, can.
Ran, can.
Give me a high five. That was so good. Laid, shade.
Laid, shade.
I like the way you kept your tongue tip up that time on the l sound.
Rat, cat.
Great job using your r and k sound.
Lose, shoes.
Great job.
Ran, can.
Good job on your r and k sound again. Give me a high five on that one. Good job. Good work.
Shade, laid.
Good job on sh and l. There are both advantages and disadvantages of using the maximal oppositions approach. An advantage to this approach would be that when children are developing their speech, they focus on the wide differences between sounds. This approach gives them the opportunity to contrast sounds that differ by various elements. A second advantage is that using two sounds in the words pairs that are not in the child's inventory has been proven to be more effective than targeting one sound at a time. A disadvantage of this approach would be that the presentation of the picture cards is repetitive, so use of engaging activities is crucial, or the child may lose interest fairly quickly.